Imagine, like a microscopic error, just a single cell in your palm, a totally standard fibroblast, right? And it receives this aberrant chemical signal and just decides to transform.
Yeah, it sprouts these smooth muscle fibers, basically turning into a contractile myofibroblast.
Exactly. And it starts pulling. And over years, your fingers are dragged inexorably right down into your palm, locked in this rigid cage of your own tissue.
It's terrifying when you think about it.
Or consider the sheer terror of like a 3-millimeter margin of error. You are in a clinic attempting to blindly release a catching tendon in a patient's thumb with a needle, and if you slip by just 3 millimeters,
Which is nothing.
right, 3 millimeters, you sever the radial digital nerve, permanently blinding that side of the thumb to sensation.
It is a profound shift in perspective, really, because, I mean, we spend so much of orthopedics looking at these stark, high-contrast x-rays of shattered bones.
Yeah, the mechanics of trauma are super obvious.
Right, but elective hand surgery, it is basically a world of shadows. You know, you're dealing with tissues that are slowly morphing or joints quietly degenerating under like decades of microscopic shear force.
Or developmental blueprints that were fundamentally rewritten before the patient was even born.
Exactly.
And that biological drama is exactly why we are here today.
Yeah.
Welcome to the series finale of this deep dive into the hand surgery curriculum. Right. Now, I know exactly who is on the other end of this audio right now.
Oh, absolutely.
You are in your car navigating traffic, or, you're pacing around your kitchen doing dishes or chores. You are in that grueling final stretch of your fellowship exam preparation.
Trauma and orthopedics, the DMB Orth, MRCS, EBOT, all of them.
Right. You are stressed out, your bandwidth is completely maxed out, and you absolutely cannot look at a textbook right now.
So let's set the terms of engagement here. This is an audio-only, heavily detailed, high-yield study session designed specifically for the multitasking mind. We are going to respect the reality of your prep right now. We are taking the remaining critical modules of this curriculum, basically everything outside of acute trauma, and synthesizing it for you.
But no dry lists, right?
No, absolutely not. We aren't just going to read you lists. We are going to explain the biomechanics and the cellular drivers so that the answers actually make logical sense.
Which honestly is the only way they will stick under the pressure of an oral exam.
Precisely. To do that, we need a spatial framework. So we are organizing this deep dive into 4 distinct structural buckets.
Okay, lay down.
Bucket 1 is the hand that stiffens. So that's your Dupuytren's disease and your trigger fingers. Bucket 2 is the hand that inflames and wears out.
Wear and tear.
Right. We will cover a Quervain's tenosynovitis, osteoarthritis of the thumb base, and of course, the devastating mechanics of the rheumatoid hand. Bucket 3, the hand that grows a lump.
In chondroma and ganglion.
Exactly. We'll break those down. And finally, bucket 4.
Oh.
The hand that was built differently. This is the congenital landscape, from polydactyly to achondroplasia.
So stiffen, wear, lump, build. I like that.
It gives us a really solid architectural progression. You know, we move from the superficial fascia and tendons down into the joints, then into the bone, and finally to the genetic blueprint itself.
That makes perfect sense. And a vital housekeeping rule before we dive into bucket 1. Because you are driving or, washing dishes and you cannot write anything down, we are going to do the heavy lifting for your working memory.
Yes.
My co-host is going to state every single critical number, every list, and every exam discriminator exactly twice.
Twice. Auditory reinforcement through spaced repetition is really how you conquer these exams when your hands are literally on the steering wheel.
Repetition is key.
It is. I'm also going to surgically extract and correct 3 famously flawed answer keys that are just floating around in the major question banks.
Oh man, those are the worst.
They are. We are going to clean up those faulty premises so you don't lose points to bad data.
Love it. Let's get straight into it. Block A, the stiffening hand. We are looking at conditions that restrict glide and lock the hand in place. Let's start with Dupuytren's disease. We touched on the myofibroblast in the intro, but let's break down the actual pathology. Like, why is this actually happening?
Well, to understand the pathology, you really have to understand the normal anatomy first. So the palmar fascia is this intricate, tough, triangular sheet of collagen right beneath the skin.
Okay.
Its normal job is basically to anchor the palmar skin so it doesn't just slide around when you hit something heavy like a hammer. But in Dupuytren's, a switch flips.
Sure.
Normal fibroblasts undergo a phenotypic change into myofibroblasts.
And myo implies muscle. So these cells actually gain the ability to physically contract.
Precisely. They develop these alpha-smooth muscle actin microfilaments, and then they begin laying down vast, chaotic amounts of type 3 collagen.
Instead of the normal type I.
Exactly, instead of the orderly type I. And then they physically contract. Clinically, you first see this as an indurated nodule in the palm, usually over on the ulnar side.
Like near the pinky.
Right. As the cells keep pulling and organizing, that little nodule extends into these thick rope-like cords that just drag the fingers downward into flexion.
Okay, let's talk about those fingers and the joints they actually cross. Which ones are taking the hit here?
It predominantly affects the ring and little fingers. The contracture forces the metacarpophalangeal joint, the MCP, right at the base of the finger, and the proximal interphalangeal joint, the PIP, right in the middle into flexion.
Got it. Base and middle.
Oddly enough, the terminal joint, the DIP, is typically spared, or it might even hyperextend. But here is the critical exam discriminator that always catches people out. They will ask you about the joint capsules themselves.
Right, because the disease originates in the fascia, which is way above the joint capsule. So instinct says the capsule should be totally fine.
And that is the exact trap. The trap statement on the exam is that the joint capsules are spared. That is biologically false over time.
Oh, because of the prolonged position.
Yes. The persistent, unrelenting flexion position eventually causes a secondary contracture of the joint capsule and the collateral ligaments. So let me state this discriminator twice for you.
Go for it.
The joint capsules DO eventually become affected by the contracture. Beware of the false statement that they are spared. Again, the joint capsules DO eventually become affected by the contracture. Do not select the option that says they remain spared.
Okay, locked in. Now, I want to visualize these cords because the anatomy here is an absolute minefield for the surgeon. I'm imagining the palm like a complex suspension bridge with all these cables running underneath the skin.
That's a really great way to view it. Normally, the cables are just neat bands, protendinous bands, natatory ligaments. But in Dupuytren's, they thicken into these diseased cords. You have the protendinous cord, the central cord, the lateral cord, but the absolute villain of the hand, the one that causes surgeons to actively sweat, is the spiral cord.
Why the spiral cord? Walk me through its path. What makes it so dangerous?
It is dangerous because of its three-dimensional geometry. So it starts from the protendinous band in the palm, it dives deep to bypass the neurovascular bundle, and then it spirals back up to attach to the side of the finger.
Okay, I'm visualizing that.
Now think about what happens when a spiral tightens.
It tries to become a straight line.
Exactly. As this cord contracts and straightens out over time, it physically hooks the digital nerve and artery and drags them completely out of their normal anatomical position.
It pulls them right into the surgical approach path, doesn't it?
It drags them directly under the skin where you are making your incision. You need to know exactly how they are displaced for the exam. I will state this twice. The spiral cord displaces the neurovascular bundle superficial, central, and proximal once more. The spiral cord displaces the neurovascular bundle superficial, central, and proximal.
So if you cut down, expecting the nerve to be in its normal, deep, and lateral spot,
you will completely transect it.
Man, that is brutal. Let's back up to the cellular level for a second. We have the myofibroblast doing all the heavy lifting, pulling the cords. But who is actually giving the order? What chemical messenger is telling these cells to proliferate? There's a huge cytokine trap here that shows up constantly.
Yeah, the fibrotic cascade is super complex. You have interleukins, platelet-derived growth factor, nerve growth factor. But the absolute primary driver, like the master switch for myofibroblast differentiation, is transforming growth factor beta, TGF-beta.
But the examiners love to test your reading comprehension, right? They change one letter.
They do. They will give you a list of cytokines and ask which one is not implicated, or they will ask for the odd one out in the pathology, and they rely on you reading too fast. The trap answer is transforming growth factor alpha.
Alpha?
Right. TGF-beta is not the driver. So stated twice. TGF-beta drives the disease. The exam trap odd one out is TGF-alpha. Again, TGF-beta drives the disease. The exam trap odd one out is TGF-alpha. Beta is bad. Alpha is the answer.
Beta is bad. Okay, that's a good mnemonic. Let's talk about the patient profile now. Who actually gets this? And more importantly, how do we know if it's going to come back aggressively after we operate? That's the diathesis, right?
Yes, exactly. Diathesis basically implies a severe constitutional predisposition to a rapidly progressive and highly recurrent form of the disease. The biology is just inherently more aggressive. Historically, there were 4 classic factors.
Oh, were they?
Age of onset under 50, a positive family history, bilateral disease in both hands, and the presence of ectopic lesions.
Let's break down ectopic for a second, outside the hand.
Correct. It's the exact same fibrotic process happening in other fascial planes. So Peyronie's disease in the Darquis fascia of the penis, Lederho's disease in the plantar fascia of the foot, and Gerard's knuckle pads, which are these fibrotic deposits on the dorsal aspect of the PIP joints.
Right.
Now, more recently, Hindocha's research added 2 major demographic and clinical factors to this list.
Okay, let's lock the whole comprehensive list in. For the listener driving right now, give us the full diathesis criteria, including those additions.
Here is the comprehensive diathesis list, stated twice. The factors for aggressive recurrence are young age under 50, positive family history, bilateral disease, ectopic lesions, PLUS male sex, and more than 2 rays involved in the hand.
Okay, one more time.
Let's do that again. The recurrence factors are young age under 50, positive family history, bilateral disease, ectopic lesions, PLUS male sex, and more than 2 rays involved.
You mentioned male sex. The exam usually wants a hard ratio for that.
It does. It is overwhelmingly male-dominated. The male-to-female ratio is roughly 10-to-1.
Wow, 10-to-1.
Yeah. You also see strong associations with Northern European ancestry. It's often called the Viking disease, as well as systemic stressors like diabetes, epilepsy, and alcohol dependency.
Is there a biological link there?
The working theory is that microvascular ischemia from these systemic conditions triggers the release of oxygen-free radicals, which in turn stimulates that TGF-beta pathway we just talked about.
Everything loops back to TGF-beta.
Okay, so a patient with a heavy diathesis profile sits in your clinic. Their hand is curled up. How do you objectively decide on a physical exam that it is time to intervene surgically?
The decision really rests on Houston's tabletop test. It is a brilliant, zero-cost biomechanical test.
How does it work?
You ask the patient to place their hand, palm down, completely flat on a hard surface like a desk. If they can press the palm completely flat, the test is negative. You just observe them.
Okay, but if they can't?
If the flexion contracture is severe enough that the palm cannot lie flat and the fingers sort of tent up, forming a tunnel under the hand, that is a positive Houston's tabletop test. That mechanical failure is your indication for surgical release.
So they fail the tabletop test and you book them for surgery.
Right.
Now, I want to challenge the biomechanics here because this is where instinct totally fails.
You have 2 joints stuck in flexion. The MCP joint down at the big meaty base of the finger and the PIP joint right in the middle of the slender digit. Intuitively, I'd assume the massive MCP joint with all those strong intrinsic muscles around it would be much harder to permanently correct than the little PIP joint.
And your intuition is exactly what the examiners are preying on.
Oh, really?
It is biologically backwards. The MCP joint contracture, no matter how grotesque it looks, is usually a relatively straightforward correction. You divide the protendinous cord and the joint simply springs open. We usually wait until the MCP hits about 30 degrees of flexion before intervening because the surgical payoff is so reliable.
Wow. And the PIP.
The PIP joint, however, is an absolute nightmare.
Why? What makes the PIP so stubborn?
It's the anatomy of the collateral ligaments. The PIP joint is a hinge. When it flexes, the collateral ligaments slacken. If it is held in flexion for months by Dupuytren's cord, those ligaments physically shorten and adapt to that new length.
Oh, they shrink?
Yes. Even if you completely excise the diseased cord, the joint is now locked tight by its own shrunken ligaments and capsule. Any significant PIP contracture is an indication to operate early because once it's stuck, it is incredibly difficult to fix.
So the exam strat is going to reverse that reality.
Exactly. The false statement they want you to select is MCP contractures are more difficult to correct than PIP contractures. Let me state the reality twice.
Please do.
MCP contractures are easier to correct. PIP contractures are much harder to correct. Again, MCP contractures are easier to correct. PIP contractures are much harder to correct.
That is a critical distinction.
Right.
Okay, so if we synthesize this, the key takeaway for Dupuytren's is that TGF-beta drives the myofibroblast. The diathesis includes young age, family history, bilateral, ectopic lesions, male sex, and over 2 rays. You operate based on a positive Houston's tabletop test, and you remember that the PIP joint is the true enemy of correction.
Spot on.
Let's seamlessly transition to our second stiffening condition. We move from cords pulling the finger shut to a tendon mechanically wedging itself in a tunnel. Trigger finger and thumb. Walk me through the biomechanics of this friction lock.
So the flexor tendons of your fingers run through a series of tight fibrous tunnels, or pulleys, to keep them close to the bone, like guides on a fishing rod.
Right.
The very first one at the base of the digit is the A1 pulley. It takes an immense amount of shear force during normal grip. In trigger finger, usually due to microtrauma or inflammation, a mismatch develops. Either the flexor tendon itself swells into a lump, which is known as Nada's nodule, or the A1 pulley thickens and tightens down.
So it's a size discrepancy. Basically, the rope is too thick for the eyelet.
Precisely. As the patient tries to flex or extend, that thickened nodule struggles to squeeze through the A1 tunnel. It gets stuck, builds up tension, and then finally pops through with a painful click. That is the trigger.
And we categorize the severity using Green's grading system, right? I know this is highly testable. Let's focus on the boundary lines.
Green's grading is essential. Grade hurt is pre-triggering. The patient has pain, they have tenderness at the A1 pulley, but you cannot make it physically catch during your exam. Grade 2 is the absolute sweet spot for exam questions.
Let's dissect Grade 2. What defines it mechanically?
Grade 2 is defined by active, demonstrable catching, but, and this is the vital discriminator, the patient retains the ability to actively extend the finger using their own extensor muscle power.
So the engine is still strong enough to yank the nodule back through the tight pulley?
Exactly. In grade 3, that power fails. Grade 3 requires the patient to use their opposite hand to passively pull the locked finger straight. Grade 3 means it's stuck in flexion and they can't even make a fist anymore. And grade 3 is just a permanent, fixed flexion contracture.
Okay, the line between Grade 2 and 3 is active power. Let's state the discriminator for Grade 2 twice.
Stated twice. Green's grade 2 is demonstrable catching with preserved active extension. Once more, grade 2 is demonstrable catching with preserved active extension.
Now, adults get this from wear and tear, but children get this too. Is the pediatric pathology just like a miniature version of the adult?
Not structurally, and definitely not epidemiologically. This is a massive distinction for the boards. In the adult population, you see trigger fingers constantly. In children, trigger thumb is vastly more prevalent.
Really? How much more?
Pediatric trigger thumb is about 10 times more common than pediatric trigger finger.
10 times. Why the huge discrepancy?
It's largely anatomical and developmental. Children often present with a thumb that is completely locked in flexion at the interphalangeal joint. Parents frequently rush to the clinic thinking the thumb is broken or dislocated.
Oh, I bet.
But it's usually just a very prominent, tight Nada's nodule caught at the A1 pulley. So remember, trigger thumb is 10 times commoner than trigger finger in children.
Let's talk about the surgical implications, because operating on tiny pediatric hands is super high stakes. If you are releasing a pediatric trigger thumb, what is the specific anatomical hazard?
The hazard is the radial digital nerve of the thumb. Because of the way the thumb pronates and positions itself, that radial digital nerve takes a very oblique course right across your operative field. It sits terrifyingly close to the A1 pulley. If your dissection isn't meticulous, you will cut it.
And what if it is a pediatric trigger finger? Let's say you open it, you carefully divide the A1 pulley, but you test it on the table and the tendon is still catching. What is the biological reason, and what is your next surgical move?
The biological reason is that pediatric trigger fingers are far more anatomically chaotic than adults. The restriction isn't always just isolated to the A1 pulley. The restriction can actually be caused by an abnormal decussation, which is the splitting point of the flexor digitorum superficialis, or FDS, tendon deeper in the sheath.
So the A1 release isn't enough.
Right. If you release A1 and it still triggers, you must extend your incision. You do an extensile approach and you release one slip of that FDS tendon, specifically the ulnar slip.
And if that doesn't work?
If it still triggers, you then release the A3 pulley, or the remaining radial slip of the FDS.
Extensile incision, ulnar slip of FDS, then A3. Good to know. Now let's talk about the adult side again and bring in our first answer key fix of the episode.
Oh, this one is a classic.
The percutaneous release. This is where you use an 18-gauge needle in the clinic to blindly sweep and cut the A1 pulley without making a skin incision, right?
Yes. Percutaneous A1 release is a widely accepted and safe procedure for the index, middle, and ring fingers. The digital nerves run laterally, well out of the midline trajectory of your needle. But attempting this in the thumb is deeply controversial and highly dangerous.
Let's explain exactly why it's dangerous, bringing in that margin of error we talked about in the intro.
A classic anatomical study mapped this out perfectly. They measured the distance from the standard percutaneous needle entry point to the radial digital nerve of the thumb. The average distance was less than 3 millimeters.
Less than 3 millimeters, wow.
In half the specimens, it was under 2 millimeters, one microscopic twitch of the patient or a tiny slip of your hand, and you have completely skewered the nerve.
Which brings us to the flawed exam question.
Exactly. There is a prominent practice question out there that asks, what structure is most at risk during a percutaneous trigger thumb release? The answer key marks the volar plate.
Wait, the volar plate?
Yes, and this is anatomically nonsensical. The volar plate is a thick cartilaginous structure deep to the flexor tendons, resting right against the bone. To hit the volar plate, you would have to drive the needle completely through the tendon itself. The actual structure at risk, sitting superficial and right adjacent to your target, is the radial digital nerve.
Let's clear the cache on that false key. State the correction twice for us.
I will state this twice. The structure at risk in a percutaneous thumb release is the radial digital nerve of the thumb, not the volar plate. Again, the structure at risk in a percutaneous thumb release is the radial digital nerve of the thumb, not the volar plate. You should generally just avoid percutaneous release in the thumb entirely.
Perfect. So, synthesizing, triggering. Green-grade sick is catching with preserved active extension. Pediatric thumb is 10 times more common than the finger. And the radial digital nerve is the critical structure at risk, especially in the thumb.
Exactly.
Let's close out Block A with the final condition that limits tendon glide. The Quervain tenosynovitis. We're moving from the palm up to the wrist. Where are we anatomically, and what exactly is inflamed?
We are on the radial aspect of the wrist, looking at the first dorsal extensor compartment. This is a fibro-osseous tunnel. Inside it run two critical tendons, the abductor pollicis longus, or APL, and the extensor pollicis brevis, the EPB.
Okay, APL and EPB.
Right. In Quervain's, repetitive motion causes a stenosing tenosynovitis, which is a swelling of the tendon sheath and a thickening of the compartment roof, essentially choking those two tendons.
And there is an embryological or anatomical quirk inside that tunnel that guarantees surgical failure if you miss it, isn't there?
Yes, there is. In a significant percentage of the population, the compartment isn't just one big room. There is a distinct, separate subsheath isolating the EPB tendon.
Oh, like a hidden compartment.
Exactly. If you go in surgically, make an incision, see the big, meaty APL tendon pop out and think, great, compartment release, job done, you will fail. The EPB will remain trapped in its hidden subsheath, and the patient's pain will persist. You must actively hunt for the EPB subsheath.
How do we provoke this pain in the clinic to diagnose it in the first place? What's the biomechanical test?
It is Finkelstein's test. You instruct the patient to tuck their thumb flat against their palm and fold their fingers over it, locking the thumb in place. Then, the examiner sharply deviates the wrist in the ulnar direction.
Ouch.
Yeah, it aggressively yanks the APL and EPB tendons against the tight, inflamed roof of the first compartment, producing this sharp, exquisite pain over the radial styloid.
Let's lock in the geography. State the compartment and the tendons twice.
Stated twice, de Quervain's involves the first dorsal extensor compartment containing the APL and EPB tendons again. De Quervain's involves the first dorsal extensor compartment containing the APL and EPB tendons.
Synthesizing the Quervain's. First dorsal compartment, APL and EPB. Finkelstein's test is the diagnostic mechanical stretch, and you must hunt for the EPB subsheath surgically.
Spot on.
All right. That concludes Block A. Let's do a rapid recalibration recap before we shift gears. I will fire off the conceptual buzzwords. You give me the absolute core discriminator to cement it into the listener's short-term memory. Ready?
Ready.
Dupuytren's cellular driver and the cytokine trap.
Driven by the myofibroblasts and TGF-beta, the odd one out trap is TGF-alpha.
The devastating path of the spiral cord.
It displaces the neurovascular bundles, superficial, central, and proximal.
The counterintuitive correctability trap.
MCP contractures are easier to correct. PIP contractures are much harder.
Trigger finger grade 2 definition.
Demonstrable catching, but with preserved active extension.
The percutaneous thumb release danger.
The radial digital nerve of the thumb, not the volar plate.
De Quervain's anatomy.
First dorsal compartment, APL, and EPB.
Outstanding. All right, take a breath. Keep your eyes on the road. We are shifting into Block B. The worn and lumpy hand.
This is where things get destructive.
Yeah, we are moving away from tendons locking up and focusing on joints that are mechanically grinding themselves away and the tissues that form masses as a result. Let's start with a classic clinical vignette. A 65-year-old woman comes to your clinic. She complains of a deep, aching pain at the base of her thumb, particularly when she tries to open a tough jam jar or turn a key. When you inspect her hand visually, what morphological change are you looking for?
You are looking for a visual squaring of the thumb base, This is the absolute hallmark of osteoarthritis at the first carpometacarpal joint, the trapeziometacarpal joint, where the trapezium bone articulates with the first metacarpal.
But why does it turn square? That's kind of a bizarre anatomical shift.
It's basically a biomechanical collapse. The trapeziometacarpal joint is a saddle joint. It has incredible mobility, but it relies heavily on the anterior oblique ligament for stability. When you pinch something, the forces at the tip of your thumb are multiplied massively by the time they reach that basal joint.
Like a lever arm.
Exactly. Over decades, that force just wears away the cartilage. The ligament attenuates, the joint subluxates radially and dorsally, and massive osteophytes, which are bone spurs, form in an attempt to stabilize the chaos. That bony overgrowth and subluxation replaces the smooth, sweeping curve of the thumb base with a hard, right-angled, bony block, a square.
Now, how do we confidently differentiate this from the Quervains we just talked about? Both are older patients complaining of pain on the radial side of the wrist.
It comes down to tissue texture and provocation. De Quervain's is a soft tissue problem. The swelling feels boggy, it's localized to the tendon sheath over the styloid, and the pain is triggered by Finkelstein's stretch.
And thumb base OA.
Thumb base OA is a bone problem. The swelling is hard, fixed, and exactly at the joint line. You provoke the pain not by stretching, but by compression, the CMC grind test. You actually load the thumb and rotate it, physically grinding the bare bone of the metacarpal against the bare bone of the trapezium. Bony swelling and grinding versus soft tissue swelling and stretching.
Okay, let's look at another consequence of osteoarthritis, but at the very opposite end of the finger. A patient presents with a slowly growing, slightly translucent mass right over the DIP joint, the terminal knuckle just behind the nail. And peculiarly, the fingernail itself has a deep groove or a ridged deformity running vertically down it. What is the mechanism here?
You are describing a mucus cyst, but the name is actually slightly misleading. It is fundamentally a ganglion cyst, and it is the direct result of underlying osteoarthritis in that DIP joint.
Walk me through the plumbing of how an arthritic joint creates a cyst all the way under the nail.
Well, as the DIP joint degenerates, it forms sharp, dorsal osteophytes bone spurs pointing upwards. These spurs irritate and eventually erode a tiny hole in the dorsal joint capsule. Synovial fluid from the joint begins to leak out through this defect. It pools under the skin, forming a cyst.
And the nail groove, where does that come from?
The cyst forms right over the germinal matrix of the nail. As it expands, it physically presses down on the cells that are manufacturing the nail plate. It acts like a die stamp in a factory, pressing a continuous longitudinal groove or trough into the new nail as it grows out.
So understanding that plumbing brings me to a surgical challenge. Let me push back on standard logic here for a second.
Okay, go ahead.
If it is just a fluid-filled balloon under the skin, why not just numb it, make a tiny nick, excise the balloon, and send the patient home? Why does the textbook insist on a much deeper operation?
Because if you just excise the balloon, you haven't fixed the leak and you haven't removed the thorn that caused it. The recurrence rate will be astronomical. The cyst is merely a symptom. The underlying osteophyte is the true disease. If you don't remove the sharp bone spur, it will just erode the capsule again and generate a brand new cyst. The surgical imperative is that you must address the bone.
This is a classic exam discriminator, isn't it?
Yes. I will state the required treatment twice. To definitively treat a mucus cyst, you must excise the cyst A and D, the underlying DIP osteophytes. Again, to treat a mucus cyst, you must excise the cyst A and D, debride the underlying DIP osteophytes. If an exam option suggests just removing the nail or just resecting the cyst without mentioning the osteophyte, it is the wrong answer.
Synthesizing this, thumb-base pain with a hard, bony square is trapeziometacarpal OA. A DIP mass with a nail groove is a mucus cyst, and the treatment demands excising the cyst A and D, debriding the driving osteophytes. Next, in the Warren lumpy block, we face the most devastating acquired wear and tear condition, the rheumatoid hand. This disease doesn't just wear cartilage away, it actively destroys the architecture. Let's focus on the heavy hitters for the fellowship exams. Let's talk about silicone MCP joint arthroplasty, essentially, replacing the knuckles. When is this indicated?
Assuming the extensor tendons are still intact and functioning, silicone MCP arthroplasty is reserved for a specific triad of catastrophic joint failure. First, there must be gross architectural destruction of the articular surface.
Okay, bone destruction.
Second, there is a classic volar and proximal dislocation of the proximal phalanx. The base of the finger literally drops down and slides backwards underneath the metacarpal head, And third, there is marked ulnar drift, where the fingers sweep violently away toward the ulnar side of the hand.
But you can't just put new knuckles into a collapsing building, right? Is there a prerequisite step? Do you have to check the foundation first?
Absolutely. And the foundation of the hand is the wrist, the carpus. You must evaluate the alignment of the carpus before touching the MCP joints.
Why? What is the mechanical link between the wrist and the fingers there?
Think of the hand as a Z shape in severe rheumatoid disease. If the carpus collapses into severe radial deviation, it acts as a lever. The flexor and extensor tendons crossing the wrist are now pulling from an altered, decentralized angle. They biomechanically drag the fingers into ulnar drift to compensate.
Oh, wow. So they pull everything sideways.
Right. If you just put brand new silicone MCP joints into that hostile mechanical environment, the radial deviation of the wrist will simply tear your new joints apart and force them right back into ulnar drift. So if the carpus is radially deviated, you must reconstruct and realign the wrist first before you even consider the MCP arthroplasty.
That structural logic is brilliant. Now, that brings us to the most famous, most tested concept in rheumatoid hand surgery. A patient presents with a cascade of rheumatoid disasters. They have a fraying tendon rubbing over a jagged bone spur. They have carpal tunnel syndrome because their synovium is massively swollen and crushing the median nerve. Their joints are aching constantly, and their fingers are cosmetically crooked. You cannot fix it all at once. What is the absolute surgical priority order?
This priority list is the gospel of rheumatoid surgery, and it is entirely based on preventing irreversible, permanent biological loss. I will state the list twice.
Let's lock it in.
First priority, impending tendon rupture or severe nerve compression. Second priority, relief of pain. Third priority, improvement of function. Fourth and final priority, cosmesis.
Let's explain the why. Why do tendon and nerve trump agonizing pain?
Because pain, functional deficits, and cosmetic alignment can wait a month without the basic anatomy changing. But a nerve dying from relentless ischemic compression cannot wait. If the median nerve loses its blood supply due to synovial crushing, it will die, and the motor function is lost forever.
And tendons.
Similarly, if an extensor tendon is rubbing over a sharp rheumatoid bone spur-like in von Jackson syndrome, where the ulnar head erodes the extensor tendons, it will snap. Once it snaps and retracts, fixing it becomes infinitely more complex, requiring tendon transfers rather than just decompression. You must intervene on structures that are about to fail catastrophically and permanently.
Let's lock that hierarchy in.
Stated twice. The surgical priority order in the rheumatoid hand is 1. Impending tendon rupture or nerve compression. 2. Pain relief. 3. Function. 4. Cosmesis. Again, 1. Impending tendon rupture or nerve compression. 2. Pain relief. 3. Function. 4. Cosmesis.
Synthesizing the rheumatoid hand. Silicone MCP arthroplasty addresses gross destruction, volar dislocation, and ulnar drift. But you must correct a radially deviated wrist first. And the prime directive of surgery is saving tendons and nerves before addressing pain or function.
Exactly.
Rounding out Block B, let's move away from joints and talk about the two most common isolated lumps you'll encounter. Let's start with one. The enchondroma. What is the pathology here?
The enchondroma is the single most common primary bone tumor of the hand. Biologically, it is a benign cluster of hyaline cartilage that somehow got left behind inside the medullary canal of the bone during development.
Just stuck in there.
Right. It sits inside the bone, slowly growing, and its absolute favorite location is the proximal phalanx of the fingers.
Does the patient feel this cartilage expanding?
No, it is usually completely silent and painless. As the cartilage lobules grow, they slowly resorb the surrounding trabecular bone, basically hollowing out the inside of the phalanx and thinning the hard cortical shell from the inside out.
Like termites in a wall.
It's like turning a solid wooden beam into a hollow reed. The patient has absolutely no idea it's there until a trivial trauma like, accidentally whacking their hand against the desk causes a pathological fracture through that structurally compromised paper-thin bone. That is how they present in the emergency department.
So you have a broken finger with a massive hollow tumor inside it. Instinct tells me to cut it open, scrape the tumor out immediately, and put plates on it.
And that instinct is totally wrong.
Really?
The first step is to let biology work. You do not rush to scoop out the tumor. The fracture hematoma actually brings a massive influx of healing factors. You immobilize the finger and allow the fracture to heal first. Interestingly, sometimes the healing process itself ossifies and obliterates a small tumor.
So once the bone heals, what is the definitive plan?
You observe. If the lesion is small, painless, and the bone has remodeled well, you just leave it alone and monitor it with x-rays. You only escalate to surgery, which is an intralesional curettage where you scrape the cartilage out and pack the void with bone graft, if the lesion is exceptionally large, causing chronic pain, or represents a high risk for a recurrent fracture. Heal first, then observe the small ones.
Okay, that is the most common bone tumor. Now, what about the most common soft tissue mass overall?
That is the ganglion cyst. It represents up to 70% of all hand masses. It is a benign mucin-filled sac that arises from a joint capsule or a tendon sheath. It essentially acts like a one-way valve where fluid pumps out of the joint but cannot return.
There are many locations, but the exam zeroes in on the classic dorsal wrist ganglion, right? That prominent bump right on the back of the wrist. There's a very specific anatomical route it springs from.
Yes. While it can theoretically arise anywhere, the classic dorsal wrist ganglion originates specifically from the scapholunate interosseous ligament. This is the critical stabilizing ligament between the scaphoid and lunate bones. The cyst stalk usually arises right from the dorsal aspect of this ligament.
State that anatomical origin twice.
The classic dorsal wrist ganglion arises from the scapholunate interosseous ligament. Again, the classic dorsal wrist ganglion arises from the scapholunate interosseous ligament.
Synthesizing tumors. The enchondroma is the most common bone tumor, found in the proximal phalanx, presenting as a pathological fracture. Let it heal, then observe if small. The ganglion is the most common overall mass, and the dorsal variant springs from the scapholunate interosseous ligament.
That's the summary.
Okay, that is the end of Block B. Let's do Recap 2 to lock in the worn and lumpy hand before we hit the deep biology of the final block.
Let's do it. Thumb base OA presents as bony squaring of the trapeziometacarpal joint. A mucus cyst is driven by DIP osteoarthritis. You must excise the cyst A and D to debride the osteophytes. The rheumatoid priority order is tendon or nerve first, then pain, function, cosmesis. Enchondromas are the commonest primary bone tumor. Watch and wait after the fracture heals. And dorsal ganglions originate from the scapholunate ligament.
Excellent. Now, take a sip of coffee, roll your shoulders back. We're entering Block C, the congenital hand.
This is fascinating stuff.
We are shifting entirely away from acquired wear and tear. You're looking at the foundational developmental blueprints. These are hands that were built differently from the moment the fetal limb bud began to form. Let's start with thumb polydactyly, the presence of an extra thumb. How do we classify this spectrum of duplication?
We use the Wassel classification system, and unlike some medical classifications that seem, sort of arbitrary, this one possesses a brilliant mathematical logic. It is based on how far proximally, meaning how far down the thumb toward the wrist, the duplication extends, and it alternates between bones that are split and bones that are fully duplicated.
Break that mathematical logic down for me.
Okay. The odd numbers, types I, 3, and V, represent a bifid bone, a single bone that splits at the top like a Y, sharing one base but having two heads.
Right.
The even numbers, types 2, 4, and Vi, represent completely duplicated bones sitting side by side, totally independent. The numbering starts at the distal tip of the thumb and marches downward.
So walk us through the stages.
Type 1 is a bifid distal phalanx. Type 2 is a duplicated distal phalanx. Type 3 is a bifid proximal phalanx. Type 4 is a duplicated proximal phalanx. Type V is a bifid metacarpal, and Type 6 is a duplicated metacarpal.
That makes it incredibly easy to reconstruct in your head. Now, out of all those variations, which one is the clinical heavy hitter that shows up in half of all cases and on literally every exam?
That is Wassel type 4. It accounts for about 50% of all thumb polydactyly cases.
Let's lock in the number and the anatomy.
Stated twice. The most common type of thumb polydactyly is Wassel type 4, which is a duplicated proximal phalanx. Again, the most common type is Wassel type 4, a duplicated proximal phalanx.
Now let's flip from digits that multiplied to digits that failed to separate. Syndactyly. Webbed fingers. What is the embryological failure here?
In a normal fetus, the hand starts as a solid paddle. Then, a highly regulated process of programmed cell death apoptosis occurs in the tissue between the primitive digits, literally carving out the web spaces.
Okay, so it cuts the webbing away.
Exactly. Syndactyly is simply the failure of that apoptosis. The tissue just remains. And the most common location for this failure is the web space between the middle and ring fingers.
When a surgeon evaluates this, they use very specific terminology. Simple, complex, complete. Give me the definitions.
Simple syndactyly means the digits are fused only by skin and soft tissue. The bones are separate. Complex syndactyly means there is actual bony fusion, a synostosis, between the phalanges of the adjacent fingers.
And complete versus incomplete.
Complete means the webbing extends all the way to the absolute distal tips, incorporating the nail folds. Incomplete means the web stops somewhere proximal to the fingertips.
And there is a highly testable severe variant called acrosyndactyly. What is the pathology, and what syndrome is it handcuffed to?
Acrosyndactyly is a complex terminal fusion where the distal tips of the fingers are fused together into a mass, but there are sometimes small fenestrations or little holes in the web spaces proximal to the fusion.
That sounds bizarre.
It looks almost like a purse string was pulled at the tips. This is a hallmark pathognomonic feature of Apert syndrome.
And the genetics behind Apert syndrome.
If the exam asks for the molecular driver, Apert syndrome is caused by a mutation in the FGFR2 gene fibroblast growth factor receptor 2. This mutation fundamentally disrupts the signaling pathways that dictate that necessary apoptosis, leaving the fingers fused.
Middle ring commonest, simple is soft tissue only. Acrosyndactyly is Apert syndrome and FGFR2. Now let's look at the surgical correction. When you divide these fingers and reconstruct the web space, what is the most common complication as the child ages?
The most common post-release complication is a phenomenon called web creep. When you create the new commissure at the base of the fingers, it heals with a scar.
Right.
As the child grows rapidly, that scar tissue acts like an unyielding tether. It physically pulls the web space distally down the fingers, essentially reversing the surgery over time and rewebbing the base.
Wow, that's frustrating.
Yeah.
Is there a rigid rule on when you operate? Do you fix all webbed fingers at the exact same age?
No, and this is a critical distinction that really tests your understanding of bone growth. Most standard syndactyles, like the middle ring, can wait until the child is about 12 to 18 months old. They are safer to operate on when they are slightly larger. However, border digit syndactyly, meaning the thumb fused to the index finger or the ring finger fused to the little finger, must be released early, usually around 6 months of age.
Why the urgency for the borders?
Because of vastly different longitudinal growth rates. The middle and ring fingers grow at roughly the same pace, so if they are stuck together for a year, they don't severely distort each other.
But the borders are mismatched.
Exactly. A thumb grows entirely differently than an index finger. A ring finger grows much faster and longer than a little finger. If you leave a rapidly growing long bone tethered to a shorter bone, the tension will act like a bowstring. It will cause severe, permanent angular deformity and rotational twisting of the joints. You must release border digits early to unlock their independent growth trajectories.
Synthesizing polydactyly and syndactyly. Wassel type 4, duplicated proximal phalanx, is the most common thumb duplication. Syndactyly is commonest between middle and ring. Web creep is the major complication, and border digit syndactyly demands early release to prevent angular deformity.
Perfectly summarized.
Now let's tackle the bagdactyly confusions. Camptodactyly versus clinodactyly. These two sound identical in a panicked exam scenario. Let's use a strict spatial geometry analogy to force the listener to visualize this without a textbook. Imagine you are staring at your own hand, held out completely flat in front of you on an X and Y axis.
That works perfectly. Let's start with camptodactyly. Campto translates to bent. This is a non-traumatic flexion deformity of the PIP joint, almost always affecting the little finger.
Okay, so which axis?
It occurs entirely in the sagittal plane, the y-axis. So if your hand is held out flat, the affected little finger is bowing downward toward the floor like it is nodding on a hinge.
What's the anatomical driver, and do we rush to surgery for that?
The abnormality is usually an anomalous tightened insertion of a lumbrical muscle or the flexor digitorum superficialis tendon pulling the joint down. Interestingly, the function of the hand is rarely severely compromised. The infantile variant often responds very well to non-operative stretching and static splinting. Surgery is a last resort and is notoriously unpredictable.
So campto is nodding down in the sagittal y-axis. What about clinodactyly?
Clino translates to slope or incline. This is a fixed radial neurangulation, again, usually the little finger, but this occurs in the coronal plane, the x-axis.
Okay, keeping with the analogy.
If your hand is flat, the little finger isn't nodding downward. It is bowing sideways, hooking laterally toward the ring finger, like it is waving at you.
And the anatomical driver here is bony, right?
Exactly. It is usually caused by an abnormal wedge-shaped bone in the middle phalanx called a delta phalanx, or a bracket epiphysis, where the growth plate is C-shaped instead of flat, causing the bone to grow on a curve.
Let's explicitly lock in those spatial planes. State them twice.
Camptodactyly is a flexion deformity in the sagittal plane. Clinodactyly is a sideways deviation in the coronal plane. Both usually affect the little finger. Again, Camptodactyly is in the sagittal plane, clinodactyly is in the coronal plane.
Perfect. Now the third variant, macrodactyly, the massively disproportionately enlarged digit. The exam always tests the syndromic associations here, and they set a very specific trap.
Yes, macrodactyly is a terrifying condition where all the tissues in a digit, the nerve, the fat, the bone, the skin undergo massive asymmetrical overgrowth, often linked to the PIK3CA genetic pathway. It is strongly associated with several major syndromes: neurofibromatosis, Proteus syndrome, Klippel-Trenaunay syndrome, and Allier's disease, which is multiple enchondromatosis.
The question format is usually, which of the following syndromes is not associated with macrodactyly? What is the trap?
The trap answer is Marfan syndrome. Marfan syndrome causes arachnodactyly abnormally long, thin, spindly fingers due to a fibrillin defect. It does not cause the massive, bulky, multi-tissue overgrowth seen in macrodactyly.
State the discriminator twice to clear the trap.
Macrodactyly is not associated with Marfan syndrome. Again, macrodactyly is not associated with Marfan syndrome.
Synthesizing the dactylies. Campto is sagittal PIP flexion. Clinome is coronal sideways dowing. Macrodactyly is linked to NF, Proteus, and Klippel-Trenaunay, but absolutely not Marfan.
Right.
We are on to our second to last congenital topic, thumb hypoplasia. And this brings us to answer KeyFix #2. There is a glaring contradiction in the major source question banks regarding how you decide to surgically treat a hypoplastic, underdeveloped thumb. Can you untangle this for us?
This is a crucial fix because the underlying biomechanics dictate the entire surgical algorithm. When a child is born with an underdeveloped thumb, the surgeon faces a strict binary choice. Do you try to reconstruct and augment the existing tiny thumb, or do you amputate, ablate the useless thumb entirely and perform a policization, which is moving the index finger over to the thumb position to take its place?
It's the massive decision. What is the single anatomical factor that makes that choice for you?
The single most important variable deciding between reconstruction and policization is the structural stability of the carpometacarpal joint, the CMC joint, right at the absolute base of the thumb.
Why the CMC joint? Why does that rule all?
Because it is the foundational bedrock of pinch mechanics. If the CMC joint is stable, you have a solid post. You can transfer tendons and reconstruct ligaments around it, and the thumb will be able to resist the intense opposing forces of the fingers.
And if it isn't stable?
If the CMC joint is unstable, underdeveloped, or entirely absent, the thumb is essentially a house built on sand. No amount of soft tissue reconstruction will work. The moment the child tries to pinch, the thumb will simply collapse at the base. In that scenario, you must ablate it and policize the index finger to provide a stable post.
So where does the exam prep material go wrong?
Well, one major source question correctly identifies CMC joint stability as the answer, but a second question, featuring a slightly scrambled option list, marks MCP joint stability as the correct choice in its answer key.
The MCP. That's wrong.
Completely. But here's the absolute proof it's flawed. If you read the explanatory paragraph attached to that exact same question, the text explicitly argues that the CMC joint is the primary determinant. The key directly contradicts its own explanation text.
That is maddening for a candidate who is just trying to memorize facts. Let's fix it definitively right now. State the true determinant twice.
The single most important variable deciding between reconstruction and policization is CMC, or carpometacarpal joint stability, not the MCP. Again, the determinant for reconstruction versus ablation is CMC joint stability.
How does that anatomical rule translate into the classification system we use? We use the Blouth classification for thumb hypoplasia, right? Where's the line drawn?
The Blouth system grades the severity from I to V. The practical surgical cutoff, based entirely on that CMC stability, happens at Blouth type IIB.
What happens at IIB?
In type IIB, the proximal half of the metacarpal bone is missing, which means the CMC joint is completely gone. So, type IIB, type IAV, which is the classic Pausfladen or floating thumb, where the digit is literally just dangling by a skin bridge in a tiny neurovascular bundle with zero bony attachment, and type V, which is total absence, all lack a stable CMC foundation. Therefore, Blouth IB4 and V strictly require policization of the index finger.
Synthesizing thumb hypoplasia. CMC joint stability is the single bedrock determinant for reconstruction.
Right.
If the CMC is absent, as in a Blouth of 4 floating thumb, you must treat it with policization.
Perfect.
Which brings us to the final topic in the congenital block, and actually the last condition of the entire curriculum, achondroplasia and the trident hand.
The trident hand is a highly recognizable morphological finding. The fingers are short, stubby, and they splay outward into 3 distinct groups. There is a very noticeable widened gap between the middle and ring fingers, giving the hand the appearance of a 3-pronged trident. This is a pathognomonic marker of achondroplasia.
Let's run through the genetics and the exact bone pathology, because we have a minor correction to make to some of the source text descriptions here as well, don't we?
Yes, we do. Achondroplasia is the most common cause of short-limb dwarfism. It is an autosomal dominant genetic disorder driven by a gain-of-function mutation in the FGFR3 gene, fibroblast growth factor receptor 3.
And the correction?
The slight correction relates to how the bone fails to grow. Some source texts casually refer to it as an epithelial disorder. Strictly biologically speaking, it is a disorder of endochondral ossification, so specifically at the physis, the growth plate, not the epiphysis.
What exactly goes wrong at the growth plate?
Normal long bone growth requires cartilage cells at the physis to proliferate, line up, and then ossify into hard bone. The mutant FGFR3 receptor essentially acts as an overactive brake pedal. It constantly signals the cartilage cells to stop proliferating. Therefore, the bone cannot elongate, producing the classic rhizomelic, meaning proximal heavy shortening of the limbs.
Beyond the trident hand and short limbs, what systemic skeletal findings will the examiners expect you to know for this FGFR3 mutation?
You must remember the spine and the skull. They typically have a dangerously narrow foramen magnum at the base of the skull, which can cause cervicomedullary compression. They have frontal bothing of the skull. And critically for orthopedics, they develop severe spinal canal stenosis, which is radiographically characterized by a narrowing of the interpedicular distance in the lumbar spine as you move caudally.
Synthesizing achondroplasia. The trident hand is linked to an autosomal dominant mutation in FGFR3, causing a failure of endochondral ossification, leading to short limbs, a narrow foramen magnum, and spinal stenosis.
That covers it.
All right, we have arrived. We are entering Block D, the lightning round, and trap clear-out. This is the final sprint. We are going to use high-speed spaced repetition to hammer these discriminators into your short-term memory before you walk into the exam hall.
Let's do it.
But before the volley begins, we have our final cleanup. Answer key fix. #3. I want to flag a truly rogue question floating around out there concerning a drug called hydrazine.
Oh yeah, this one is an absolute mess and needs to be quarantined immediately. There is a flawed source question that presents an image of an intrinsic plus hand, a hand locked in a position with the MCPs flexed and the IPs extended. It attempts to attribute this deformity to drug-induced Parkinsonism, but it blames a drug it calls hydrazine, describing it as a monoamine inhibitor.
Let's dismantle why that is pharmacologically impossible.
It's completely garbled nomenclature. First of all, hydralazine is a direct-acting smooth muscle relaxant used as a vasodilator to treat severe high blood pressure. It has absolutely nothing to do with Parkinson's or monoamine inhibition.
Okay, what's the second error?
Second, while true drug-induced Parkinsonism can indeed cause dystonic hand deformities, it is typically caused by dopamine antagonists drugs like typical antipsychotics, such as haloperidol, or antiemetics like metoclopramide. The question author confused hydralazine with something else entirely. So to the listener, if you encounter that hydrazine question in your test prep, recognize it as fundamentally broken. Do not let it corrupt your pharmacology knowledge. Ignore its premise entirely.
Quarantined and deleted. Okay, here we go. The lightning round. A rapid-fire, back-and-forth volley spanning the entire deep dive. I will fire the prompt. You deliver the precise single-phrase answer. No fluff. Listener, your job is to shout the answer at your windshield before the expert says it. Ready?
Ready.
The primary contractile cell in Dupuytren's.
The myofibroblast.
The cord that dangerously displaces the neurovascular bundle.
The spiral cord.
The cytokine odd-one-out trap in Dupuytren's.
TGF-alpha, because TGF-beta is the driver.
The mechanical bedside test deciding Dupuytren surgery.
Mirshison's tabletop test.
MCP versus PIP contracture, which is easier to correct.
MCP is easier, PIP is harder.
The Dupuytren's male-to-female ratio.
10-to-1.
Define Green's grade 2 trigger finger.
Demonstrable catching, but with preserved active extension.
The structure most at risk in a percutaneous thumb trigger release.
The radial digital nerve of the thumb.
To Quervain's anatomical compartment and tendons.
First, dorsal compartment. APL and EPB.
Older female patient, hard bony squaring of the thumb base.
Trapeziometacarpal osteoarthritis.
The surgical requirement for a mucus cyst.
Excise the cyst, end bride the DIP osteophytes.
The rheumatoid arthritis surgical priority hierarchy.
Tendon or nerve first, then pain, then function, then cosmesis.
The commonest primary bone tumor of the hand.
Enchondroma, usually in the proximal phalanx.
The exact anatomical origin of the classic dorsal wrist ganglion.
The scephalinate interosseous ligament.
The most common Wassel type for thumb polydactyly.
Type 5. Duplicated proximal phalanx.
The most common syndactyly web space.
Between the middle and ring fingers.
The most common complication after a syndactyly release.
Web creep.
Planar deformity. Camptodactyly versus clinodactyly.
Campto is sagittal flexion. Clino is coronal sideways bowing.
The syndrome explicitly not linked to macrodactyly.
Marfan syndrome.
The single anatomical determinant for hyperplastic thumb reconstruction.
CMC joint stability.
The required treatment for a Blouth the Fife floating thumb.
Policization of the index finger.
The Triton hand. Condition and gene.
Achondroplasia. FGFR3.
And breathe. Wow. That closes out the lightning round, and it officially brings our epic deep dive series on hand surgery to a close.
If you have been listening across all 9 modules, you have absorbed an immense volume of complex anatomy and pathology. You've mapped the flexor and extensor engines. You've traced the intricate wiring of the ulnar and median nerves. You've decoded the collapsing mechanics of the corpus. You've survived the acute emergencies. And today, you've mastered the elective conditions, the entire hand from shoulder to fingertip.
We want to genuinely congratulate you for surviving this finale. It is a punishing curriculum, but you are putting in the unseen hours where it really counts.
The strategy from here on out is simply repetition. Keep playing this audio on your commute. Let the spaced recall do the heavy lifting for you. Pretty soon you will find that those core discriminators, the spiral cord, the CMC joint stability, the FGFR3 mutation, will just automatically appear in your mind before the examiner even finishes reading the stem of the question.
Before we sign off, I want to leave you with one final thought to mull over in the quiet of your car. We spent this entire time hyper-focused on all the ways the hand can fail. But step back and think about the profound fragility and yet the incredible redundant resilience of human anatomy.
It really is amazing.
Consider how one microscopic shift, a single normal fibroblast turning into a contractile myofibroblast, or a single altered FGFR3 gene in a billion base pair blueprint can cascade into a massive mechanical failure or a totally alien architectural structure. It really highlights the sheer microscopic precision, the delicate balance of tensions and pulleys required for you to perform something as unimaginably complex as the simple act of human grasp.
It is an unparalleled engineering marvel.
Definitely.
And understanding exactly how and why it breaks is really the only way we earn the right to try and fix it.
Exactly. Thank you for trusting us to guide you through this material. Keep re-listening, keep challenging the mechanics, and go absolutely crush that exam.
Good luck out there.
Yeah.
You have got this.